My name is Sarah Well. I'm a 12-year critical care ICU trauma nurse, and I'm in direct care of COVID-19 patients on the regular. This is in response to the nurse practitioner who accused nurses on the front line in New York City of murdering their patients. To me, this video speaks to a severe lack of understanding of the policies and procedures that we use on a day-to-day, as well as a lack of understanding of the pharmacokinetics of the medications that we use. So let's go ahead and unpack it together. In terms of going straight from nasal cannula to intubation, we do not have the ability to wait with these patients. Our patients with COVID-19 that are admitted tend to deteriorate rapidly, and if we don't intubate them as soon as possible, and that's exactly why the nasal cannula at 6 liters was created as a cutoff to intubate right away, the patients will otherwise die. So the lack of respiratory reserves, we can't even properly pre-oxygenate them when we want to intubate. They just deteriorate so rapidly, which is why this is so different than any other disease process that we've seen prior. It's not like a typical hypoxic process. We didn't just forget how to use our BiPAP and CPAP. This is directly to try to save lives. If this was to try to maintain a closed circuit, we would be able to keep them on nasal cannula longer. We would be able to put them on a non-rebreather. That is not why the policy is put into place. It's put into place to preserve lives and increase the quality of our outcomes. We have not had good success with hydroxychloroquine, to speak to the accusation of not using meds. If you know anything about this medication, it prolongs the QT interval, which could send a patient into torsade de poids, and the patient can go ahead and go into a fatal arrhythmia and die before we even have time to put on our isolation gowns and go in for a code blue. So I would strongly suggest, this is kind of scary because she has prescribing abilities, please do not prescribe hydroxychloroquine to anyone with cardiac history, and if you don't have a very recent EKG. In addition, azithromycin, all those other medications are typically mixed in the pharmacies and are sent up sometimes a few hours later. It's just a matter of how the medications are delivered. We have to temper that with how fluid volume overloaded the patient might be, if we have to fluid resuscitate for whatever reason, for sepsis. So you have to look at the whole context of the patient, understand what physiology is going on besides for COVID-19. Most patients are not only admitted with COVID-19, they have many comorbidities that we're trying to address at once. In terms of patients being just scared because they have no one with them and signing for consent, that is so far from the truth. We're not allowed to get consent from patients who are about to be intubated. Why? Because they are not of sound mind. It is not a legally binding contract. So we are not getting consent from these patients to intubate them. It's typically coming from phone consent from family. If there is a valid DNR on the charts, then we're able to honor that. Otherwise, it can be considered an emergency process, in which case we don't need consent. If we do get consent, it's phone consent from the family. We've been doing that for years for central lines and various emergency procedures. In terms of having to go up on PEEP and possibly creating barotrauma, that is a feature of how ventilators are used. This is kindergarten level ventilator ABCs. The ARDS, the acute respiratory distress syndrome that occurs from COVID-19, it creates such high peak pressures that if we don't go up on PEEP, the patient will not be appropriately oxygenated. It's just a cost-benefit analysis. In terms of code blue, the accusation that no one's going into the room, that's not true. It's just that now our processes are very organized at the top of every shift. We know who's the narrator. We can only have 5 people in the room. We know who the 2 allocated physicians are. We know who the safety spotters are. So everyone has their assigned role. So when the code blue is called overhead, there's no longer this mad rush the way that it used to be all hands on deck. It's a lot more organized. We know who has what role. And it just looks a little bit different, but it actually might end up being a better way forward even after this pandemic. In terms of using the same PPE, it's not that nurses don't care. We are in a national shortage of PPE. If you follow us at #GetMePPE, we are working so hard on trying to circumvent the typical purchasing channels that every hospital has to try to rapidly get PPE, because we are on a nationwide shortage and we are following the CDC protocols, and it lets us reuse those gowns in some hospitals. Thankfully in mine we don't have to, but we are on a shortage of N95 masks that would better protect us as nurses as well. And what that means is that we are at risk every single day that we go to work. We are at risk of getting this terrible virus. And a lot of nurses and doctors, to speak to the point of them being in these hotels, yes, they have had to move out. These nurses and doctors are not just extra manpower sitting around in a hotel. These are nurses and doctors that have had to move out of their own homes to protect elderly parents or their own families. And if that's not heroic to you, maybe you want to do some soul searching about who you consider your heroes, because we are scared. We are coming face to face with this terrible virus, and we're doing it anyway. And to speak to nurses, to the accusation that nurses don't care, that isn't true. There's so much frontline mental health trauma because nurses really do want to be with their patients in the rooms, especially because they're not able to have their families with them. As much as we can, we are, but we have to cluster our care. We're not allowed to overexpose ourselves to this virus when not necessary. So we have extension tubing that we run out of the rooms. That is correct, but we do that so that we don't have to waste extra PPE by just going in to turn off an IV pump. That would be a terrible waste of resources. In addition, we have to cluster all of our care and get everything done at the bedside at one time, and it could be a prolonged amount of time, but there are times that that patient is alone and it breaks our hearts, and there's so much frontline mental health trauma that is occurring. I've created a free platform for free counseling for nurses because they're so heartbroken about not being able to be with your loved ones all the time the way they would love to. And the typical volunteers that we have that sit with our patients are not allowed in the hospital anymore. We've cut down on manpower. We decreased the number of people that are exposed to this. So it shatters us and we're heartbroken, and nurses do cry in the clean utility rooms and they do very, very much care. But this is a very unfortunate feature of the pandemic, which is why we're telling everyone to please stay home and not spread this around or unduly confer this disease on anyone. It's just not something that you want to have or not something you want to give over to someone else. It's awful. So we do care. We do love you all. Please stay safe and be very careful about where you get your information sources. Bye.